So, welcome to my podcast series. Today we've got the final cascade Haematology Part 3 by Dr. Willebrand. So, in the top right corner, we've got our QR code for the Instagram page. So, if you don't follow, please do scan and follow. And in the bottom left corner, we have got our email. So, if you have any questions, please do email us. We'll get back to you. So, I can just hand over to Maggie now.
Hi everyone, so I am going to be talking through acquired and hereditary bleeding disorders today. So just to start with, we'll just review the clotting cascade. So on this diagram you can see the intrinsic pathway and the extrinsic pathway. Now both pathways then combine into this common pathway, and that leads to the activation of factor X, and then subsequently prothrombin becomes thrombin, and we build this thrombin fibrin activation, and that finally forms the fibrin clot. So when we look through these two pathways, when we conduct blood tests to measure these pathways, prothrombin time is the test that's used to evaluate the extrinsic and the common pathway, whereas APTT measures the intrinsic and the common pathway. The INR is a calculation that allows for the standardization of the PT time, and that just allows us to compare the PT between different labs. Oops. So both of these assays then measure the time to form this stable fibrin clot, and they'll be reported in seconds. So if you just take a second just to review the clotting cascade. So we'll move on to the haemophilias. Now, this picture is of one of the royal families, and haemophilia was very common in, I think, the Russian and the British royal family a few hundred years ago, due to the co-sanguineous relationships. And haemophilia is an X-linked condition, which meant that it would often skip generations, but it was very common in these royal families. So we'll start with the classic haemophilia, which is Haemophilia A. Now this is a factor VIII deficiency. Factor VIII is activated by thrombin. It's what we call an X-linked recessive condition, and it can occur mostly in males and homozygous females. So that's if the father has haemophilia and the mother is a carrier or has haemophilia. It can occur in heterozygous females, and they will have X inactivation. So what that means is a female will have two X chromosomes, from one from the father, one from the mother. Now, if one of those X chromosomes is affected and the other X chromosome which isn't affected is then inactivated, they will then have the condition as well. So this is usually from an XQ28 mutation, and it affects approximately 1 in 10,000 individuals. So some of these people will make a defective factor VIII protein, but others will produce insufficient amounts. Either way, they do not have enough factor VIII to achieve hemostasis. And the initial diagnosis from haemophilia, it can be due to the symptoms that are noticed. So these patients will have increased bleeding risks, which can manifest in hemarthrosis, which is effusions of blood in the joints. So commonly it can be the knee that's affected. They might have a lot of bruising, petechiae. They're at higher risk of GI bleeds. So you might get hematemesis, you might get melena. They also have an increased risk of intracerebral hemorrhages. And the initial diagnosis is often done by measuring the protein activity. There are genetic tests available, but that's often second line. And sometimes, even though this is commonly an X-linked recessive condition, it is possible to have de novo mutations too. And often for children, it's first picked up during the newborn heel prick test, which is where we test for different genetic conditions. These patients will often have severe bleeding from small injuries, and the amount of bleeding will be out of proportion to the injury they've had. And there's often oral manifestations as well. So that can be gingival hemorrhages and excessive bleeding if they have dental extractions. And with this, Haemophilia A, often patients will have an increased prothrombin time. And if you look at the assays of factor VIII in the lab, they'll have low levels of factor VIII. Okay, so just moving on. If we consider the management of Haemophilia A, often there's a lot of avoidance that's involved in these conditions. So patients will be told to avoid NSAIDs due to the increased risk of GI bleeding, to avoid aspirin, IM injections, and other antiplatelets such as clopidogrel or ticagrelor. And these are all because they increase the bleeding risk. Desmopressin can be given, and this is often given for minor surgery or bleeds that just fail to settle. And desmopressin can release factor VIII from the blood vessel walls. Sometimes patients will be given tranexamic acid as well. Tranexamic acid is often given for small cuts that just don't stop bleeding or prior to dental work. But just a caution to not use this if a patient is also suffering from hematuria. And the other thing we would recommend for these patients to avoid is IM injections, because that can increase the risk of intramuscular hemorrhages and hematomas. In severe disease, patients will need to be treated with factor VIII concentrate therapy. And this is just to raise the level of factor VIII in the blood to hemostatic levels. And what that means is we can achieve hemostasis with that level of factor VIII. That's what we're aiming for. So there's either IV recombinant or plasma concentrate factor VIII that we can give patients. There is any monoclonal antibody drug, and this is called, please forgive my pronunciation, emicizumab. This is a monoclonal antibody, and that can bridge the activated factor IX and factor X. So if we just go back to this slide, so it's factor IX into factor X. So by bridging that, we can restore the function of the missing activated factor VIII, which is what's needed for hemostasis. This is given as a subcut injection, and this would only be started by the specialty, so started by Haematology. There are other complications for these patients because often the amount of blood that they lose throughout their life, they often need recurrent transfusions. One of the complications of having recurrent transfusions is the risk of BBV. So these patients are at a higher risk of hepatitis A, B, C, and also HIV. So it's very important to test for these as well. And of course, if they test positive, we then would have to manage them. Okay, and then we'll move on to Haemophilia B, which is also known as Christmas disease. Now, this is a factor IX deficiency. Factor IX is activated by the factor 7A complex. Again, we'll just go back to the first slide. Okay, so this is where we're looking. Okay, so for factor IX. Again, this is an X-linked recessive condition, and the mutations in this condition lie at XQ27.1 to Q27.2. This is a rarer condition. It occurs in about 1 in 50,000. And again, patients often present with bruising, petechiae, hematuria, and epistaxis is quite common. And again, with this condition, it's very common to get hemarthrosis, and that can occur in the ankles, knees, elbows, and they can also have hemorrhages into muscles. Periodontal disease and dental caries is very difficult to manage in these patients because dental work can also lead to an increased risk of bleeding, and many of these patients will be at risk of retroperitoneal and CNS bleeds, which can be life-threatening. And again, because this is an X-linked recessive condition, males are typically affected, whereas female carriers are rarely symptomatic. But it's important to think, so when it's an X-linked recessive condition, the male will always receive their X chromosome from their mother, and they do not have another X chromosome to counteract that. So if they receive an affected X chromosome from their mother, they will not have anything to sort of counteract that affected protein, which is why males are more affected. However, because haemophilia often skips generations, that can be because the females that inherit the affected chromosome, X chromosome, they have another X chromosome which can counteract that, which means they're just a carrier, and that's why you often see in family trees that it skips generations. Another common site of these hemorrhages, especially in the muscles, is the iliopsoas. And bleeding into muscles as well can cause nerve compression, it can cause compartment syndrome and contractures. So in these patients, the way we investigate them, usually through blood tests. So usually their prothrombin time will be normal, whereas their APTT can be prolonged. But again, it depends on the degree of the deficiency. So less severe forms of haemophilia will not prolong the APTT. It's also very important to exclude one Willebrand disease, which we'll talk about next. It's important to consider radiological imaging for acute bleeds. So they might need, you might initially do X-rays if someone comes in with a hot swollen joint, but it's also important to think about CT scans and MRIs to get further characterization. And often if they do come in with these hemarthrosis, they will then go on to have a joint aspiration. It's important to get a baseline figure for your full blood count, LFTs and clotting. And again, we want to check for factor levels, and once we get that, we need to check if there's any mutations present. Again, with these patients, due to the increased likelihood of them receiving transfusions throughout their lifetime, we need to ascertain their BBV status. It's important to check for hepatitis, HIV. In Haemophilia B, there is a high likelihood of orthopaedic complications. So this can lead to chronic arthropathy, because they might have repeated joint bleeds. That's what sort of leads to this. And again, it mainly affects the ankles, knees, and elbows. They can also have pseudotumors. They can have encapsulated hematomas, often intramuscular, which then become bigger and bigger. And they may also get subperiosteal bleeding, and that can cause reactive new bone formation, and it can cause complete destruction of their bones. Because blood will irritate the synovium, and it can cause hypertrophy, and then this leads on to the tendency to rebleed. And again, you can get rapid degenerative arthritis, although this is more common usually in older people. So I think typically in adults, you'd be looking at the long bones and the iliopsoas muscle. So again, the management for Haemophilia B is very similar to Haemophilia A. Desmopressin is not usually as helpful. However, we can treat with recombinant factor IX, and that's the treatment of choice. In order to do this, though, you might need to think about long-term IV access to patients need PICC lines. Sometimes they might need a portacath when they're younger, especially. You also want to treat any comorbidities. Like I explained, there's a high chance of having orthopaedic complications in this disease. So you want to think about having combined clinics with orthopaedic surgeons, dental surgeons, hepatology, pediatricians, geneticists. You need physiotherapy for these people who develop chronic arthropathy. It helps preserve the muscle and joint function in these patients. And again, we're talking about an MDT approach. Some people can have home treatment as well. So you can get this IV factor IX injected about 3 times a week. And many people after childhood will learn how to do it themselves. Okay, so we'll just move on to von Willebrand disease. Now this is different. It's not an X-linked condition, it's autosomal dominant mainly. But again, you can have de novo mutations, and this it's usually a 12p13 mutation. So this is a bit different to haemophilia because it's mostly females that are affected rather than haemophilia is a more male predominant disease. And in von Willebrand disease, there's a mild to moderate bleeding tendency. And this is the commonest hereditary bleeding disorder. One of the reasons why there are more presentations in women is because they often present with menorrhagia, which then leads to the diagnosis. So the bleeding type you typically get with von Willebrand disease is more mucocutaneous. They also bruise very easily, get epistaxis, they might have prolonged bleeding from cuts. Again, be wary about dental extractions and the bleeding risk, and of course in trauma surgery. And women typically present with menorrhagia. It's less likely to have hemarthrosis and joint manifestations. Patients often actually present in the second or third decade after prolonged bleeding. This can be after having surgery for a different reason or after dental extractions, whereas with haemophilias, they can be diagnosed more in childhood. Now, so von Willebrand disease is split into different types. I'm not going to go into too much detail because I think this is above the level of medical finals, but certain types can cause thrombocytopenia. Okay, von Willebrand factor is an acute phase protein. So what that means is it can increase with stress, estrogens, pregnancy, malignancy, thyrotoxicosis. It's similar to other acute phase proteins such as ferritin. Now, the levels of this factor can fluctuate in the blood because of the variations in stress, for example. Von Willebrand factor levels are dependent on the ABO blood group, so they're naturally or typically lower in blood group O than non-O. Okay, and in this disease, patients will present with reduced levels. Okay, and not only are the levels reduced, but sometimes the function can also typically be mildly or moderately reduced. Sorry. Okay. So these are the different types. So the most common type is actually type 1. This is the least severe, and it typically presents just with reduced levels of the factor. Type 2, the factor is present, but it does not necessarily work properly. And this can then be divided into 4 different subtypes. And just for your reference, the type that can cause thrombocytopenia is 2B. Type 3, this is the least common type, and there are very, very low levels of von Willebrand factor, or it can be completely absent, and this is the one that leads to the most severe bleeding. They can often have spontaneous bleeds. Now, there's also something called pseudo von Willebrand disease, and this is similar to type 2, where the problems are with the platelets themselves rather than with the factor. Okay. So now if you just move on to consider what the management would be. Again, we can give desmopressin, which can help reduce bleeding risks. And tranexamic acid is a useful antifibrinolytic drug, and this can often be given when patients are going in for dental extraction, often in conjunction with desmopressin. If it's something minor, like minor cuts, it's very useful to sort of elevate the limb affected, apply local pressure to help reduce bleeding. And desmopressin, we were talking about earlier, which can increase the level of factor 8 in the blood, can also increase the level of von Willebrand factor. Again, you want to think about avoiding aspirin when possible and NSAIDs. NSAIDs can greatly increase your risk of gastrointestinal bleeds. And again, we want to think about vaccinations. So these patients are more likely to need blood transfusion throughout their life. They're at a higher risk of developing blood-borne viruses, such as hepatitis or HIV. So we want to make sure they've received all of their immunizations for hepatitis B and A. The other thing to consider, because as I was saying earlier, women are often very affected due to the menorrhagia, is to consider management for their periods. So often these patients will be given Mirena coils, which can reduce the duration and heaviness of their bleed. And sometimes if they're still having periods, we can give tranexamic acid. And now you can give von Willebrand factor itself or a von Willebrand factor and factor VIII concentrate. And this is often used in major surgery. Okay, so just moving on. There are other rare factor deficiencies. Now, I think this is probably above the level of finals. They're very rare. It can be 1 or 2 cases per million. Now, typically, they're autosomal recessive. So you can get type 1, which is just reduced levels of the factor, or you can get type 2, which is a production of a variant protein that doesn't work the same way. These rarer factor deficiencies rarely produce hemarthrosis, and this is other than factor. Sorry, that's the typo there. And often diagnosed at the time of surgery. So these patients might have major surgery, and then because their bleeding is increased, that's when they're diagnosed. And again, you'd want to be treating them with factor concentrates when available. There is an alternative where we can give fresh frozen plasma, and this contains several different of these factors. Your aim is, when you're treating them, is to achieve a plasma factor concentration that's at least as high as the minimal value needed for to achieve hemostasis. And you do not want them to drop below that level when you're doing surgery, because you are aiming to achieve hemostasis. Okay, so you can get factor 11 deficiency. This is more commonly seen in the Ashkenazi Jewish population. Again, they can have variable severity. Patients might have a normal PT and APTT, so it's really important to think about measuring the actual factor levels. Again, treatment can include tranexamic acid to help reduce bleeding risk and desmopressin. You can also get factor 11 concentrate, or as an alternative, you can give FFP, which contains multiple concentrates. Okay. You can also get factor 7 deficiency. Now, factor 7 is one of the vitamin K dependent factors. If we just think about what other factors are vitamin K dependent, it would be factor 10, factor 9, factor 7, factor 2. Okay, so there are some reported cases of spontaneous intracranial hemorrhages at young ages. These patients will often have prolonged PTs but have a normal APTT. And again, you're looking to check the factor levels in the blood directly, rather than, you can't just rely on the abnormal clotting results. Again, you'll be looking to treat with recombinant factor 7A, and this requires repeat doses. FFP contains all the coagulation factors, which is also useful. And just to note is recombinant factor 7A has quite a short half-life, which is why you give repeat doses. Okay, so moving on, so we've got factor 13 deficiency. Now, this can often cause delayed post-operative bleeding. So we're talking about 6 to 24 hours after having surgery, they might then stop bleeding. And you often see this in neonates when the umbilical stump after being cut does not stop bleeding. They have a very high risk of intracranial hemorrhages. In these patients, the prothrombin and APTT times will likely be normal, and you can measure the factor 13 antigen level. So you can treat them with factor 13 concentrate, which has a longer half-life. So they can be treated once a month, often with prophylaxis replacement in severe cases. And again, screening tests are not the most sensitive. And then if we move on, so from hereditary bleeding disorders, and think about other acquired bleeding disorders. Now, we know the liver is very important in coagulation, because most of the coagulation factors are made in the liver. And this includes the vitamin K dependent factors, which is 10, 9, 7, and 2. Any liver damage can cause reduction in these levels, and that can then lead to coagulopathy, often due to the short half-lives as well. As well as this, they can have increased fibrinolysis, which leads to bleeding, and they can also develop associated thrombocytopenia, which is low platelets. and that can contribute to this prolonged bleeding time. And that can be quite common in liver disease. Hemostasis is essentially a very fine balance between procoagulant and anticoagulant mechanisms, and things like liver disease can knock that balance off. So again, patients will often present with GI bleeding, so you look out for melena, variceal bleeds, they can be quite large, epistaxis, oozing from wounds, and bruising. Vitamin K deficiency itself as well can cause increased prothrombin more than the APTT. And you can also get low fibrinogen and platelet levels. Now, things that can reduce your platelet levels and cause thrombocytopenia can be due to portal hypertension, splenic pooling, alcohol, viral infection, drugs as well. Okay. And liver disease as well is more common in people with alcohol excess. It can be common in obesity, drug overdoses, hepatitis, autoimmune conditions. So it's important to screen for all of these as well. Oops, sorry. And if we just move on to the treatment, liver disease. We can often treat with vitamin K. So we give 10 milligrams once a day for 3 days. That can be given IV or subcut. And we also give FFP. Now, FFP can correct the clotting factor deficiencies, which can then lead to correction of the PT or APTT times. You also want to be aware of any other medications they're on that can increase the bleeding risk. So stop any NSAIDs if they're on low molecular weight heparins or etc. See if you can stop them as well. You can also give cryoprecipitate, or you can give a prothrombin complex. In terms of transfusions, they might need transfusion of red cells, but we can also transfuse platelets. So you can transfuse a pool of platelets. Desmopressin again can improve the function of platelets. If people do present with liver disease, you might be thinking about doing a liver biopsy. Now, typically, if you want to do a biopsy, you'd be aiming for the INR to be less than 1.4 and platelets to be above 50. If you attempt this procedure, you'd want to be giving FFP at the same time and keep checking the INR and clotting pre-procedure and post-procedure. Now, if patients present and they're actively bleeding, so this can often be from variceal bleeds or GI bleeds, you'd be thinking about transfusion. This can include platelets and red cells. You'd want to give vitamin K, FFP, a pool of platelets, and you might require surgical intervention. You might require endoscopic intervention. So if people present with variceal bleeds, they can sometimes take them into endoscopy, insert a Senstachen tube, bandit, the varices, etc. And one of the other important things to be aware of in liver disease is disseminated intravascular coagulation. We'll just move on. This is a rare but very life-threatening condition. Essentially what happens is there's accelerated clotting within the blood vessels, which uses up a lot of the platelets and clotting factors, and that then leads to uncontrollable bleeding. So patients are both in this procoagulant and anticoagulant state at once. Okay. And it can often manifest with these bruising and petechiae around their body, so which is why it's very important to always do an A2E examination. Patients with DIC are typically very unwell. They might not be able to give you a coherent history. You might not get that much information from them, which is why it's so important to do a full A2E top to toe examination. Expose the patient, look for these bruising, because this could point you in the right direction. Okay, so DIC, it's a systemic activation of these coagulation factors, and that results in the generation of fibrin clots that cause organ failure and consume platelets and coagulation factors, which can result in bleeding. Now, it can be due to a number of things. So it's very commonly seen in sepsis, especially undiagnosed sepsis. It can be seen in trauma patients, if patients have organ necrosis, which is common in pancreatitis. Also in obstetric complications, things like amniotic fluid emboli, or placental abruption. Again, liver failure and the ingestion of toxins. In DIC, you'd be wanting to test the coagulation, so PTA, PTT, the fibrinogen levels. You'd want to test a D-dimer, full blood count. As well as that, you'd think about doing your basics, so LFTs, renal profile, CRP for a baseline as well. This is a clinical diagnosis. You can't rely on one laboratory test, but the mainstay of treatment is to treat the underlying disorder. If a patient has a very severe infection, treat them with antibiotics. If it's an obstetric complication, they might need an emergency C-section delivery. And again, if there's signs of organ necrosis, other trauma, they might need surgical intervention. There is a high risk of bleeding, so you'd be wanting to transfuse these patients if their platelets are below 50. And again, think about giving fresh frozen plasma if the patient is bleeding and the PTA, PTT is prolonged. You can also give prothrombin complex concentrate, and that can be given if FFPP is not available or possible in patients with bleeding. And this can be because often patients will be overloaded. So if you're giving them lots and lots of FFP, it can increase that overload, might lead to pulmonary edema. If you don't want to do that, you can consider PCC. It's very important in these patients to involve haematology early on and involve all the specialties. Okay. Often, if it's younger people who present with DIC, you'd be wanting to involve ITU early on as well. And also, just to clarify, when we talk about high risk of bleeding in DIC, it's patients who might be post-operative or who need to undergo an invasive procedure. So that's why you would consider transfusing them even if their platelets are sort of just below 50. Patients aren't bleeding, you'd be more thinking about transfusing if platelets drop to about 20. Another very common iatrogenic increased risk of bleeding is from anticoagulation. Now, we anticoagulate a lot of patients, so there are different anticoagulants to consider. Warfarin, which is often, it's being phased out now for some conditions, but patients who have metallic heart valves, etc., will be on warfarin. There's low molecular weight heparins. They can be given for patients who are in hospital who have reduced mobility, and that's just as DVT prophylaxis. It can also be used to treat DVTs. We give it after, for example, orthopaedic surgeries when patients are non-weight bearing for up to 6 weeks. Some patients might be on unfractionated heparins or NOACs, so they're your apixabans, rivaroxabans, dabigatrans. So we'll just talk a bit about the different anticoagulants. So if we just start with heparin, the main advantage over sort of NOACs is that you get an immediate anticoagulant effect, and it has a short half-life. So we can either give unfractionated heparins or low molecular weight heparins. Low molecular weight heparins have a greater bioavailability. The other advantages is it's once daily, usually it's a subcut injection. Patients can be taught how to do this themselves. There's no specific monitoring requirement. There's no dose adjustment that's needed. We don't need to start off at a dose and then titrate upwards. And there's a lower risk of heparin-induced thrombocytopenia. Now, heparins can act by potentiating coagulation inhibitor, antithrombin, which results in antithrombin and anti-factor Xa activity. So these are usually, low molecular weight heparins are usually prescribed by weight, and unfractionated heparins can be given if the creatinine clearance, which we work out using something called the Cockcroft-Gault equation, is under 30. It's better for your kidneys. And both of these heparins require renal clearance. So things to consider is if your platelet levels drop, it's what we then consider with these anticoagulations. So the heparins, you might want to stop them. Warfarin is a vitamin K antagonist. It can take a longer time to become effective. So with heparins, you get an immediate anticoagulation effect. Warfarins, to reach the therapeutic level, can take maybe up to about 6 days to be effective. So warfarin as well. Free warfarin is active, but it circulates and it's mainly bound to albumin. There are many drugs that can increase the warfarin effect, and that's because they displace them from the albumin in the blood. And again, you'd want to monitor warfarin more closely. So we use something called the INR, and this is just a standardized version of the prothrombin time between laboratories. Warfarin is usually given daily, and like we said, because it takes sometimes maybe like 5-6 days to reach its therapeutic effect, if someone needs immediate anticoagulation, you might need to bridge them with heparin. So we give both until their INR is in a satisfactory place, so it's within the target range. Then you stop the heparin. NOACs, so apixaban, rivaroxaban, etc., they're factor 10A inhibitors. So you can give vitamin K to reverse effects, especially for warfarin. And if patients do present with severe or life-threatening bleeding, because they're on anticoagulation, you can give factor 9, or you can give fresh frozen plasma, which contains all the coagulation factors. And one of the things just to note is the NICE guidelines for CTs. This has a section for patients who have presented with a head injury and are on anticoagulation or antiplatelet medication. So I'll just read the guidance out for you. So it's for people who have sustained a head injury and have no other indications for a CT scan, but are on anticoagulant treatment. That includes vitamin K antagonists, direct-acting oral anticoagulants, heparin and low molecular weight heparins, or antiplatelet treatment, excluding aspirin monotherapy. So you'd be thinking more about DAPT, so people who might have had PCI recently. Consider doing a CT head scan within 8 hours of the injury. So what you're thinking about is if a patient who is anticoagulated falls and hits their head, they are at a higher risk of having an intracerebral bleed, and it's very important to scan just to exclude that. Okay, so we'll just do a few example SBAs. So the first question, if a well male and a female who is a Haemophilia A carrier have a baby, what are the chances of an unaffected child? So just remember, Haemophilia A is an X-linked recessive disorder. Okay, so we will just move on. And there you go. So the answer is 50%. So we'll just talk through this question. There are two possibilities here that they could have either a son or a daughter. So you can draw out a diagram if you please. Sometimes that helps you visualize it better in exams. But there is a 25% chance that a son will inherit the Y. So if they're to have a son, they will always inherit the Y chromosome from the father. So there's a 25% chance they'll have a Y and the X-linked recessive non-working gene copy, so the affected gene from the mother. There's also a 25% chance that they have a son, again, Y chromosome always from the dad, but they have the working non-affected copy of the X-linked gene from the mother. And then if we consider the XX phenotype, so XX genotype, there is a 25% chance that the daughter will inherit both working copies of the X-linked genes. So she gets the healthy X from dad, also gets the healthy X from mum. But there's a 25% chance that the daughter will inherit a healthy X from dad and the affected X from the mum. And that means that the daughter, hopefully, if the working X isn't inactivated, she will be a carrier. Okay, so it's about 50%, the risk. And then this is another question. So in this question, 4-year-old boy comes to clinic. They have bloods taken after being admitted for a chest infection. But unfortunately, the child was bleeding for quite some time, which was deemed to be abnormal after having his bloods taken. And then you decide to examine the child. Again, very important to do an A to E examination, top to tail, expose the patient, have a look at their skin. And you also notice multiple petechiae on his legs, without any history of significant trauma other than the usual bumps one would associate with a 4-year-old child. You speak to mum, and then mum remembers that her brother had the same problem when he was young, but she hasn't seen him for a long time because they're estranged. We do some blood work, and the blood tests then show the prothrombin times 12 seconds, which is normal. APTT is raised, and fibrinogen is 2.2 grams, which is in the normal range. Because this APTT is deranged, you decide to do some further tests, and the 1 Willebrand factor level is normal. The factor 8 assay is reduced, whilst factor 9 is normal. What is the most likely cause of the above presentation? Okay, so we'll just show the answer. So it would be Haemophilia A in this case. So we'll just talk through it. So this is a non-specific presentation, so this is why you need the blood tests. Given the family history, this is more likely to be an inherited condition. It is always important to consider non-accidental injuries, but typically kids who present with non-accidental injuries might be more likely to have bruises rather than petechiae. The blood tests more or less rule out abuse being a cause of these symptoms in this case. As 1 Willebrand factor is normal, it is unlikely to be 1 Willebrand disease. Factor 9 as well is normal, so therefore Haemophilia B is an unlikely diagnosis. Haemophilia A is associated with factor 8 deficiency, which is what is mentioned here. So that would be the answer. Okay. And just to talk through some useful mnemonics, I still use this now. So 1972 wept. So I'm sure you'd have heard of this, but factors 10, 9, 7, and 2 are the vitamin K dependent factors. And wept is warfarin. Acts on the extrinsic pathway, which is measured using the prothrombin time. So 1972 wept. And conversely, obviously, if warfarin affects the extrinsic, heparin acts on the intrinsic pathway, and that is used. We use the APTT, which is the activated partial thromboplastin time, to check it. Right. Now, I think this is quite niche topics. Some of it is probably above the level of what you need to know for finals. But haemophilia is a very good example of X-linked recessive inheritance, which can sometimes come up through genetic pedigree diagram questions in finals. But it's definitely something to be aware of, and you will see a lot of liver disease once you start working as a doctor, and it's always important to rule out iatrogenic causes of bleeding and to be wary of DIC once you start working. Okay, so thank you very much for listening. Please let us know if you've got any questions, and as well as that, if you just scan this QR code, you will get access to a feedback form, which is very useful for us, and it's both useful once you start working. You'll realise it's useful to put onto portfolios, but it's also useful to improve these teaching sessions and see what people prefer to help their learning. You'll also get access to the slides once you submit a feedback form. So thank you very much for listening. The QR code is here if you want to scan it, and there's also should be a link in the description.